Welcome, everyone. It is just noon Eastern Time. I'm Angela Duckworth, and I'd like to open up today with Allison. I want to give you a sense of who Behavior Change for Good is to begin, then I'm going to pass the mic to Allison. The Behavior Change for Good initiative is actually a consortium of scientists, world-class scientists from many different disciplines. And what unites these academics is a desire to understand the science of behavior change. And in particular, when we think about the pandemic, we recall even early, maybe in the first weeks of the pandemic, that it was clearly human behavior change that was an essential part of overcoming the virus. So not just biomedical breakthroughs. I mean, think about mask wearing as an example. And then to take the example that we're going to talk about today, vaccination. Once we had vaccines against COVID-19, and once there was adequate supply, at least here in the United States, we had a demand problem. And anticipating this, the scientists at Behavior Change for Good wanted to ask the question, and did ask the question, how can we encourage adults in the United States to get vaccinated? In anticipation of the COVID vaccine, this is now going back 1 year. So last fall, we got together and we did a mega study, a massive trial where multiple scientific teams tried multiple and different ideas to encourage vaccination. In that case, 1 year ago, against the flu, so that we could understand messaging that would work to encourage vaccination more broadly. And so that is what we're going to be discussing today. You know, everything that behavioral scientists have learned about this critical topic. And with that, let me pass the mic to Allison Buttenheim, a good friend, and of course, a member here as well.
Thanks, Angela. Hi, everyone. I'm Allison Buttenheim. I'm on faculty at the School of Nursing at Penn, also scientific director at the Center for Health Incentives and Behavioral Economics, aka CHIBE. CHIBE's a leading research center nationally, applying behavioral science and behavioral insights to health behavior change of all types, many clinical domains on both the individual side and the provider side, in clinical encounters and in populations and in the community. We love partnering with BCFG, and you'll hear about some of those collaborations today. And we'll also wrap up the session with Kevin Volpe, our founding director, for some synthesis and next steps. One of the reasons I'm really excited about today is, for over a year, policymakers of all types, from local to national, have been asking us for evidence on what works to support this vaccine rollout. And at the beginning, a year ago, we had a lot of hunches and hypotheses from previous vaccine rollouts, from previous public health emergencies, but there really wasn't a playbook for this vaccine and this rollout. And it's been terrific in partnership with BCFG to help generate some of that evidence and to do it with rigor, but to do it rapidly, and importantly, to have it be policy responsive, to answer questions that policymakers had almost in real time about how to support vaccine demand. A couple housekeeping details, and then I'll turn it over to our panelists. Please, as the panelists speak, use our Q&A function to throw questions in that you want discussed during our Q&A portion, and feel free to upvote other questions that you'd also like answered. But we also really encourage people to use the chat function as well, to comment, to have conversations with each other. Some robust back and forth in the chat would really be welcome. So I am just going to highlight very briefly, sort of a sentence each, who you're going to hear from, and we'll also drop links to our speaker bios in the chat as we go. We're going to first hear from Katie Milkman, who, along with Angela, directs Behavior Change for Good and is also a Wharton professor. After that, Linnea Gandhi, who's a doctoral student at Wharton, will speak. And finally, Harsha Tiramurti, who is an associate professor in our Medical Ethics and Health Policy Department at the School of Medicine at Penn, and is also one of our associate directors at CHIBE, where he directs the Global Health portfolio. You'll be hearing from Harsha as well. Then we'll do a Q&A, and as I mentioned, Kevin Volpe will wrap up. So with that, let me pass the mic to Katie Milkman.
Thank you, Allison, and thank you to Allison and Angela for setting the stage so nicely for what we're going to share today. I'm going to share some slides, and I'm excited to start telling you about some data we collected. Here we go. All right, so I'm going to tell you about two mega studies that Angela previews previewed that we ran in the fall of 2020 with the goal of generating insights based on what messaging worked to encourage flu vaccination that would be portable to immediately deploy and use to encourage COVID-19 vaccination. We wanted to have insights that were really ready to go. And just to preview what may be on many minds as you're thinking, well, gosh, the flu is really different than COVID-19. I want to highlight that some of our amazing team scientists led by Heng-Chen Dai of UCLA and Sylvia Sicardo of Carnegie Mellon took the best performing insights we ended up with that I'll tell you about today, and then tested those as tools to encourage COVID-19 vaccination, and indeed found that they were effective. So that was really exciting work that that this queued up. Okay, so we ran 2 mega studies in the fall to try to understand what would be the best messages to use if we wanted to promote vaccination. And again, we're looking at the flu. We wanted to look at actual behavior because we know from past research that just asking people, will this change your decision, is not necessarily actually correlated with what people really follow through on. A mega study is a massive randomized controlled trial that instead of testing a single idea, tests dozens of ideas or tens of ideas or many more than one. And that way we can see in a head-to-head comparison, what is the best performer and understand cost effectiveness and so on. We felt that this was the perfect moment to use this tool to gain insights about what would encourage vaccination. So the first mega study we ran was with 2 local health systems, Penn Medicine and Geisinger Health, both large health systems in the Northeast with millions of patients. And in these cases, what we were interested in was, could we send messages to people who had a healthy doctor's visit coming up? They were going to see their doctor in person that might change decisions those patients would make when offered a flu vaccine at their doctor's appointment. So the design of this study was to test 19 different text messages sent in the 3 days leading up to that in-person appointment, encouraging people to accept a vaccine when it was offered to them by their doctor. And we had a giant team of collaborators, economists, psychologists, computer scientists, doctors who designed these messages with that goal of encouraging flu vaccination and with the goal of designing messages that could then be redeployed to encourage COVID-19. And they tested all sorts of ideas. I won't list all of them, but they ranged from encouraging people to dedicate their flu shot to a loved one. We dedicate our marathon runs and many other activities to loved ones. Maybe dedicating a flu shot to a loved one would increase your altruism and your motivation. We tried telling people a joke about the flu. Have you heard the one about the flu? Don't spread it around. That was one of my favorites. And the idea was that it would sort of give you an earbug. You'd be thinking about it. You'd have a positive attitude. Maybe you'd even tell other people the joke and you wouldn't forget and you'd follow through. Some messages encouraged you to get a flu shot to protect other people because we know sometimes thinking about others rather than your own health can be more motivating to change behavior. And then one team tested the idea that a flu shot has been reserved for you. And I actually want to shout out to Allison Buttenheim, who helped develop this idea with Gretchen Chapman, highlighting that essentially it's a default, it's available, it's set aside for you. There's some ownership language in there. And what we found when we tested all of those messages head to head, first thing I want to highlight is if we look at text messages as a whole, and this is just a graph showing on the x-axis, the regression estimated increase in vaccination against a baseline, which is sort of business as usual. We don't message you specifically via text about the flu vaccine, though we're messaging you about your appointment. That led to a 42% vaccination rate roughly. And we get that vaccination rate all the way up to a 46.4% rate with our very best performing message. But if we pool all of the text messages, just sending text message reminders did effectively increase vaccination. And all of the dots in red were messages that significantly outperformed control. And I'm sure many of you thinking about multiple comparisons issues. And when we adjust for that, we can still say we see robust results where many more treatments are working than you'd expect by chance. The best performer significantly outperforms the control, and that was telling people that a flu vaccine has been reserved for you. And by the way, the flu shot joke was not apparently as successful as I thought it would be. We were actually quite bad at predicting what would work. I just want to highlight to you what this reserve for you messaging looked like. That was our top performer, which therefore leads us to want to suggest that as a tool we could use in the future. Really very basic language that looks like what you'd expect to get from a clinician telling you you have an appointment coming up, there's an available flu vaccine in the first message, and then 24 hours beforehand, a much shorter message saying, please make sure that you ask your doctor to receive this flu vaccine that's been reserved for you. And I also want to note that of the 19 messages tested, the 3 top performers all used reserved for you languages and none of the other messages did. So that was a very strong signal of the effectiveness of this. So big takeaway, this reserved for you language seemed incredibly promising based on this study. And when we did an attribute analysis to try to understand what were the things that really rose to the top, and this was led by Angela and Linnea, who are both on this call as well, they found that framing things in these reserved for you terms was important, but it was also important that the message be congruent with the kind of thing you expect to get from your provider. So when there was interactivity, when jokes are told, when we're sending you pictures, people did not seem to respond very well to that. And the more sort of simple messages that you're used to getting from a health provider were more effective. Okay, the second mega study we ran was with Walmart pharmacies, and you might think that encouraging vaccination from a pharmacy would be a pretty different decision than accepting a vaccine when you're already seeing your healthcare provider and they offer one. And so we thought another study in that setting was warranted. We teamed up with Walmart pharmacies, and 700,000 of their customers were messaged in this trial. Here we developed and tested 22 different text messaging strategies thanks to the ideas submitted by team scientists. And a sample of what we tested, these were different messages than what we tested in the other setting I just described, because it's a different situation. You have to get in your car, drive to the pharmacy, ask for a vaccine. We sent these messages on September 25th of 2020. And then for 3 days afterwards, there might've been follow-up messages. And we tested some of the same psychology, but some different things too. Get a shot to protect your family and friends, getting people to make a commitment and text back and say, yes, I plan to get a shot. We were actually not permitted to use the reserved for you language. There was an anxiety that if we said that and then customers came and there was a stock out, it could be upsetting. And so instead we went with language, a shot is waiting for you, to convey that sort of ownership sense in a couple of the different treatment arms. And here what we found, first of all, we have huge statistical power because of the 700,000 person sample. Vaccination rates at baseline were about 30% of the population. Every text message outperformed that significantly. So again, really strong evidence that just texting people reminders to get a flu shot works. It moves the needle, pun intended. But there was significant variability in how well different messages performed. And that's important too. So we can optimize the messaging once we know we have a useful reminder tool. And the very best messages, again, use this ownership language. A flu shot is waiting for you at Walmart outperformed the rest of the messages that we tested. Though many other things, again, worked, that rose to the top. And here's what that looked like. Again, really simple messages. It's flu season, you can get a flu shot. We'll send you another text. And then remember, a flu shot is waiting for you at Walmart 3 days later. Key takeaway here, these top performers are so consistent that it's really encouraging, I think, to suggest that this ownership language is important. And then here, key things that rose to the top when we did an attribute analysis were multiple messages outperformed one, so that nagging really seemed to work here. And also that this language of ownership was important. So as I mentioned at the beginning, we feel so lucky that science worked the way we always want science to work, which is that these findings get out there. Last December, we had an inkling of what was working. A couple of members of our team sort of took the baton, ran with it, and did an amazing study, a randomized control trial last January and February with UCLA medical system, and proved that the same kind of ownership messaging was effective at increasing vaccination against COVID-19. I also want to mention that there was some follow-up work done in Rhode Island in May and June, suggesting that in a population where there were far, far fewer that actually were taking up vaccines, it wasn't enough. So whereas 20 to 30% of the people, if I'm remembering the numbers correctly, in this trial at UCLA were getting vaccinated when they got messages, in Rhode Island, something like 2% were. And then that, when you're getting such low rates, it didn't matter if you use ownership language or not. So you have to be in a setting where there's some potential to change behavior for this to work, but it seems like we should be trying these ownership language messages in any population where there's hope of moving the needle, and booster shots are a great candidate. So let me stop there and turn this over to Linnea, who's going to talk about the Philly Vax sweepstakes.
Great. Thank you, Katie. Thank you so much. Let me just share my screen here. All right. So I love the work that Katie just presented all around messaging for boosting vaccination. We're going to switch gears now and talk about using money to help boost vaccination rates. And specifically, I'm going to share with you the results of a study run this past summer called the Philadelphia Vax Sweepstakes. And there were many different collaborators and organizations helping out. Many of the individuals you see on this slide are actually on this call today, and I felt very fortunate to be part of the team with them. The main experiment that I'm going to speak about was one where we tried to see if raising the odds of winning in this lottery would in turn raise the motivation of individuals to go out and get a COVID-19 vaccine. Now, the Philly Vax Sweepstakes was one of many different vaccine lotteries that you may have been aware of over this past summer. What I want to call out at the beginning here are two key design features that are different about the Philly Vax Sweepstakes from any of the other vaccine lotteries, at least to my knowledge, that have been running at the state level. The first one to make note of is that what we ran was a regret lottery. In all of the other vaccine lotteries that have been running, they're really traditional lotteries, meaning for your name to be drawn to win a prize in this lottery, you had to have already gotten a COVID-19 vaccine. In a regret lottery, which is what we ran, all you had to be was a resident of Philadelphia. So whether or not you got a COVID-19 vaccine, your name could be drawn from the pool of people. And we operationalize this by having a residential database, as well as the potential for people to manually register as a safeguard. Now, how does this actually work then? Well, when your name gets drawn to win a potential prize in this lottery, we find out whether or not you actually got vaccinated. And if you didn't, you don't get to claim your prize and a new name is drawn. This is the beauty of the regret lotteries, this feeling of getting so close to winning, but then not getting that prize. And the hope is that with the regret lottery design, you're then able to give additional boost, additional motivation to get your vaccination because you don't want to be in that position. So that's the first design feature to really highlight about this lottery in contrast to the other lotteries you may have been familiar with. The other one, and this was the focus of the research, was our ability to embed an experiment inside the lottery where some individuals had higher odds of winning a prize than others. And we wanted to see if those higher odds actually boosted motivation to go out and get your COVID-19 vaccine. Now, we had $400,000 from a very generous donor to allocate across 3 drawings. And in each of those drawings, we gave away 2 $50,000 prizes, 4 $5,000 prizes, and 6 $1,000 prizes. Had we run this like any other lottery, we would have just drawn names from anywhere in Philadelphia, and everybody would have had the same odds of winning a prize. Instead, we split those prize levels down the middle, such that half of the prizes at each level, at each category, went to individuals whose names were drawn from one specific zip code in Philadelphia, and the other half came from names drawn from anywhere else in Philadelphia, which meant if you're a resident of this priority zip code, you have much higher odds of winning a prize. And that's how we operationalize the differences in odds. Now, a really salient question is, how do you pick what zip code gets that priority? This actually gave us an opportunity to focus the benefits of this lottery towards the most underserved vulnerable populations in Philadelphia at the time, which meant for us drawing the 20 zip codes with the lowest vaccination rates per capita in late May. That became our pool of zip codes who were eligible to become priority in any one of those 3 drawings. And in each drawing, we randomly chose one zip code from that pool of 20 to be priority. So I'll just show you what that looked like. On June 7th, we announced the whole sweepstakes, and we also drew our first priority lottery, which happened to be 19126. So if you were a resident in 19126, you knew at the subsequent drawing on June 21st that you would have higher odds of winning, which meant if you haven't yet gotten your COVID-19 vaccine, you're going to use the next 2 weeks to go out and hopefully get it so that if your name is drawn, you'll be able to claim your prize. On June 21st, we announced the winners of the first lottery, and we did the whole thing over again, where we drew another zip code from that pool of 20. This time it was 19133. And they had priority odds. So if you lived in that zip code and you hadn't yet gotten vaccinated, you would hopefully be more motivated to go out and get it over the next 2 weeks so you could take advantage of your higher odds on July 6th. And then we've repeated it a third time for Lottery 3. How much, though, did these odds go up? I'm going to show you here in this bar chart the absolute odds of winning a prize in a drawing for the priority zip, which is in blue, and all other zips, which is in red. Now, this is actually pretty meaningful if you think about relative odds. In drawing number 1, the priority zip code had almost 100 times the odds of winning a prize compared to everybody else in Philadelphia. In drawing 2 and drawing 3, it was a little lower, around 60 times the odds. This is kind of like taking someone and saying, instead of having a 1 in 200,000 chance of winning, you actually have a 1 in 2,000 or 3,000 chance of winning any one of those prizes in the drawing. So we tried to get the word out about this because it's not worth it if people don't understand and know their odds through a variety of marketing and social media campaigns. So I'll just show you a couple here. This is an example from a press release that we put out during the launch of the sweepstakes, when notably we had the most national and local attention. We also put out different text messages. This is an example from an emergency text message system called Ready Philadelphia. And our partner Penn Medicine put out text messages to their patients in the Philadelphia area, all trying to highlight, hey, if you're in one of these priority zip codes, you've got some higher odds of winning, go get your vaccine. Now the question then is, did it work? So to evaluate if it worked, we did a difference in difference analysis comparing our 3 priority zip codes, which I'm showing you here in dark green. So priority zip code 1, 2, and 3. We compared these 3 zip codes to our 17 controls. These are the other zip codes from that pool of 20 who didn't get drawn but were eligible to become priority. And we're going to look at the first dose vaccination rates by week, comparing the priority zip codes to these control zip codes, and see if there's a difference in the difference over time. So I'll show you the results with one zip code at a time. So here I'm going to show you data across all the weeks of this summer, and we're going to focus on what happens during that key 2-week period of time when the first zip code that was priority knew that if they didn't get their vaccine by now, they wouldn't be able to take advantage of higher odds on June 21st. So we should presume that we could see a boost in first dose vaccination between those 2 lines. This is our data. We are going to focus on what is happening with that blue dot, which represents our priority zip code, compared to our red dot, the 17 control zips. And if you focus between the 2 purple lines, you actually can see it looks like there is a pretty good lift there, that there's a boost in the first dose vaccination rates for our priority zip compared to our 17 control zips. Our OLS regression does estimate a positive coefficient, but unfortunately, it's just not quite statistically significant. So while this data is quite optimistic, we can't conclusively say that for sure these higher odds boosted vaccination rates. How about zip codes 2 and 3? I'll show you zip code 2 on the left and 3 on the right. Remember, these had slightly lower odds of 60 times the rest of Philadelphia. We are now going to focus on the purple lines that represent the 2-week period of time for each of these zip codes when they had priority odds. For our second zip code, when you eyeball the graph, it's hard to see that there's any difference, and the model reflects that, looking like a null result, that there wasn't a difference in terms of vaccination rates. And for our third zip code, if you look between those 2 purple lines, it indeed looks a bit like the blue dot went a little bit down, which is echoed by our OLS regression, having a negative coefficient, but like these other ones, it's not statistically significant, so we can't confidently say either way. When we pool the data across zip codes 1, 2, and 3, we're actually able to estimate a pretty precise null result, meaning raising these odds, giving these zip codes higher odds of winning in their respective drawings did not seem to impact first dose vaccination rates either way. Now, stepping back, instead of just thinking of this only as a null result, you could also go back to the first zip code and say, well, we think we see a boost there. There might be an overall effect. If you were optimistic in reading into it, you might say, well, let's say I rolled this out. What is the upper bound that I could expect, looking at our confidence interval here? And we can estimate that's about a 9% boost. So if you're optimistic and looking at the upper bound of our confidence interval, we can say maybe a high odds vaccine lottery can boost vaccination rates by 9%. In our data, we can also suggest whether or not that's worth it. So it translates to about 53 incremental first dose vaccinations at a cost of about $3,500 each. So again, this is our upper bound of what we might be able to expect given the data we have. And one of the things we've been thinking about as a team is that given the cost involved, it's probably not worth it at this time of the pandemic. There are probably more cost-effective tools available to policymakers. So thinking about takeaways, that is the first and main one, is that maybe high odds vaccine lotteries could have worked earlier on when vaccines were first made available, when maybe it was more about ease and speed to get vaccinated. But at this point in the pandemic, they don't seem to be as effective. The second takeaway that we've really been chewing on is how we can disentangle odds from awareness. We can make odds higher all day long, but if nobody is aware of them, then it's hard to say that they're going to work either way. And we don't have good empirics for this, but we do have a nice proxy, which is registrations on that manual registration website that I mentioned. Now, this wasn't required for people to do, but it is a good proxy for awareness. We might think that if you're in a priority zip code, you would sign up for this, you would register more than if you were in a control zip code. And we can use that to see how aware these different zip codes were. So just quickly as we wrap up here, I'll show you that data, which we've just been pulling together. I'm showing you here is the percent of people in a zip code who manually registered. And what I've highlighted darker here is the 2-week period of time for Lottery 1 when the blue, the priority zip code, was priority. And you can see a greater percentage of people sign up. This also is echoed for Lottery 2 and Lottery 3, of the blue bar being higher than the red bar, indicating that people in a priority zip code are more likely to manually register during the 2-week period when they are priority. But the overall takeaway from this slide, we think, is to look at that first lottery. If you recall from the data, this is where we saw the most optimistic results. We also had the greatest local and national media coverage, and we see the greatest uptake in registration. So it might suggest that high odds vaccine lotteries could work if we could really mobilize a lot of attention across channels to make sure people were aware of it. So the last thing I want to suggest or share before I move on to the next speaker is that I think the most exciting part of this research is that we were able to pull off an experiment in partnership with the city of Philadelphia in a policy rollout. We hope that this gives inspiration to other policymakers and partners out there that it can be done, and it's a great way to be able to evaluate high stakes policies while helping underserved communities. And with that, I'll thank my collaborators and turn it over to Harsha.
Thanks so much, Linnea. And hi, everyone. I hope you can see my slides here. So having seen the results from the randomized controlled trial that Katie presented, and then the Philly's VAX sweepstakes, I'm going to zoom out to the national level and present to you an observational data analysis that my colleagues and I have done looking at the effect of these statewide incentive programs in promoting COVID-19 vaccinations. So this is work with several co-authors. Actually, many of them are here in this event. And so I want to acknowledge their contributions here, as well as the research assistants who supported this project. So we're all aware that many states, in fact, around in the country, have been making an effort to increase COVID-19 vaccinations. And this, as Angela alluded to this at the top of the hour, is really around mid-April when there was a recognition that daily vaccination rates were declining, even though vaccination coverage overall had not yet reached the target levels. And so around this time, as vaccination rates started to decline, and in fact, that kept happening throughout most of this summer, we had a number of states that experimented, so to speak, with incentive programs that they hoped would motivate people to seek COVID-19 vaccinations. Now, the highest profile example of this statewide incentive program is the one that was introduced in Ohio. Many of you have probably heard about it. It got a lot of press. It was the first vaccine lottery implemented at the entire state level. And what Ohio did in this case was offer people who did get vaccinated a chance to win grand prizes of up to $1 million, and also for adolescents and younger people, it did offer the chance to win college scholarships. Got a lot of press, not just in terms of national coverage, but also within the state. It was closely watched in terms of the drawings that were held every week, in which a winner of $1 million was announced. What was interesting to us as we read about Ohio's experience is that many different states in the weeks and months that followed introduced very similar programs. So Louisiana had a similar vaccine lottery, and so did the state of Michigan, and indeed on and on. A number of states did very similar things and had these statewide incentive programs that really, at the end of the day, were lotteries that enabled people who did get vaccinated to have a chance to win these big prizes. And also, interestingly, there were some other states in the country that didn't go the route of offering lotteries, which many economists and behavioral scientists have hypothesized can be really motivating to people in terms of adopting a certain behavior. But these other states opted to offer what we call guaranteed rewards, which is that every individual who got vaccinated is guaranteed to be able to get some type of reward. In some states, like the state of New Jersey, for a short while, there was a reward in the form of a free beverage at participating restaurants. So that's an example of a very small guaranteed reward, but there were other states where the guaranteed rewards were slightly larger in size. So in the state of West Virginia, there were $100 savings bonds for people in certain age groups. And then even in the state of California, there were $50 gift cards for newly vaccinated individuals. So at the end of the day, what we're interested in is understanding, if we take stock of all the data from the states in the US, whether these statewide incentive programs were effective in increasing vaccination rates. And there's actually been a number of other studies that have looked at this question. The state that's been most carefully studied is Ohio, probably because it was the first to introduce these types of programs. And the evidence overall has been mixed. There's been some studies showing that in Ohio, the incentive program was effective, and then there are others that found that there was no effect at all. And in contrast to the statewide incentive programs and those evaluations, there have been a few randomized controlled trials from different parts of the world, also looking at this question about paying people to get vaccinated. And here I've put up two studies, two randomized trials of guaranteed incentive programs. Now, we wanted to zoom out, as I said, to the national level and see if we could come with some broad takeaways in terms of whether these incentive programs were effective or not. And what we did is collect the data over the summer, assemble essentially all the information about statewide incentive programs that were introduced in the US, looking at data that was made available by the National Governors Association, doing Google News searches, and then we linked that up with the daily vaccinations taking place in each state in the US from the CDC. So we focused on this period during between April 1st and July 29th, when there was this sustained decline in vaccination rates. And what we're doing is essentially running a difference in differences analysis, comparing the states that did introduce vaccination incentives to states that didn't have those incentive programs. We're adjusting for the trends that are taking place in the country at this time. As you'll see in one of the figures that I'll show you, vaccination rates were declining throughout in all of the states at this time. And so it's really important to make sure that we're adjusting for what's happening in the background here. And we're also going to look at some of the short-term responses to these statewide incentive programs. So just to give you a snapshot of what these data look like, there were 24 states, interestingly, that introduced statewide incentive programs during this period, starting in late April, going all the way through through mid-July. There were a number of states that introduced incentives, and given that these incentive programs came relatively late in the rollout of vaccines, it's notable that the median population that was the median percentage of the population that was vaccinated here was 44%. So in many states, when incentive programs are being introduced, about 40% of people have already been vaccinated. What I said about the trends is important here. Just if you look at this figure, what we're showing is the vaccine doses administered every day in states that did introduce incentives. Those are shown in the blue dots, and states that didn't introduce incentives. And you can see that overall there's this decline that's persistent in this period in both of those states, both of those types of states. And so what the analysis is going to do is really adjust for the fact that these trends are declining, and it's going to ask the question, are the vaccination incentive programs able to either slow down or reverse the decline once the programs get introduced? So here's the main result from the paper, and I should say this is a preprint right now that's under review. You can share a link to it in the chat. But this figure essentially shows you the trend in vaccination rates, the difference in the trends between incentive program states and the comparison states that didn't have incentive programs. And it shows you these patterns in the 14 days prior to the start of an incentive program and the 14 days after. Now, if these incentive programs were effective in increasing vaccination rates, what you would start to see is on the right side of the vertical bar, you'd start to see a positive gap emerge between the two states. And clearly the dots here, you can see that generally speaking, they hover around 0. And the confidence intervals include the null effect of there being no change and no difference in vaccination trends between the two types of states. It's also notable when we do these types of analysis, it's important to compare what was happening prior to the vaccination incentive period. And it's in fact here reassuring that the states look very similar in their trends prior to those programs being introduced. So this is one of the main kind of visual displays of the results that shows you that by and large, we're able to conclude from this study that there is no association between the incentive programs being introduced and vaccination rates. We can also, and this is in the paper, we can also zoom out and look at the entire period when incentive programs were in effect, not just those first 14 days. And what we're seeing here is that there's no significant association, and if anything, the association here is slightly negative, but not statistically significant. So there's a decline of 9 daily vaccinations per 100,000 individuals, which equates to about a 2% decline, not statistically significant, once vaccination incentive programs are introduced. It's also important to think about what kind of statistical power we have here to consider what conclusions we can then draw about the effectiveness of these programs. And what we're able to rule out with a lot of confidence in this analysis is that these incentive programs, we can say with certainty that they did not increase vaccination incentive rates by 10% or more. And that's notable when you compare the results to some other trials of guaranteed incentive programs that have been out there. We did a few additional subgroup analyses, and I'll mention those before I close. One question we had going into this is whether the guaranteed incentive programs were different in their effectiveness than the lottery incentive programs. In our data set, what we observed in general is that lottery incentive programs are much more common. There's only a few states that had guaranteed rewards that they provided. But nonetheless, we don't see a difference between the effectiveness of the two types of programs. We see some evidence that when programs are introduced relatively later, which is in late May or June or July, those programs tend to be less effective than programs that were introduced earlier. I think that's important to keep in mind when we compare studies that that evaluate the experience of Ohio relative to some other states, perhaps. And then another interesting finding here is that the incentives do appear to be more effective in Republican-leaning states, where they actually increased vaccination rates by 10% or more. So this increase of 57 doses administered per 100,000 individuals every day equates to a 10% increase relative to their underlying vaccination rates. Whereas in Democratic-leaning states, there's actually a negative and significant decline. So one concern that many people have had, and one reason why incentives sometimes are controversial, is that people often worry sometimes that they may be counterproductive in these cases. And our main result doesn't show that they had any effect either in favor or against increasing vaccination rates, but certainly these results at the subgroup analyses suggest that there are some cases in which there is a negative association. So finally, why were incentive programs not effective? Now, this is not a question we can definitively answer, but we have some hypotheses. One is that the probabilities of winning these lottery prizes may have been too small. As Linnea mentioned, how you design these rewards and what kinds of probabilities you offer can make a difference. But at the statewide level, in many cases, the probabilities were extremely small. And also the guaranteed rewards that were offered tended to be fairly small as well, so ranging from $5 to $50. The other factor, of course, is that we're dealing with a population that is more resistant or more hesitant to get vaccinated, and so that makes the need for larger incentives even greater potentially. So that could be one other reason. And finally, the fact that these incentive programs are being introduced at the same time that people are concurrently being exposed to misinformation, I think also makes it much harder for the programs to succeed. So in conclusion, we can say from our analyses that there's no association between incentive programs and vaccination rates. We do think that larger rewards may be necessary for increasing vaccination rates. It's notable that the Biden administration's called for rewards of $100 or more to be offered. It's not a question that has been tested in any of the studies yet, but there's a hypothesis that they may be more likely to succeed. And then finally, if we set aside incentives, alternative approaches like mandates are likely to be more effective. So I'll stop there and open this up for discussion. Thank you.
Great, thanks, Harsha. And going to bring back our panelists. There's about 3 hours worth of really interesting questions and topics for debate going on. I wish we had the 3 hours to talk about this together, but encourage everyone to read through the questions and comments. Katie, I'm going to start with a question to you about sort of subgroup effects, but also timing. Is there anything we can conclude from the mega studies about whether these messages work better for some groups versus others and work better at different moments, at least in the flu shot season?
Yeah, great questions. What I will say is I was surprised by how little heterogeneity we saw in the results, meaning we'd try, slicing subgroups by age, by all sorts of different characteristics, and we didn't see huge differences. Now, I think one difference that you saw in your own sub-study, Allison, was based on whether or not people had gotten a vaccine in a prior year, which seemed to boost effect size maybe a little bit. Maybe those folks had higher intentions, and so closing that action intention gap was more feasible with a simple reminder. But there wasn't much there when we looked at things like age and gender. And one result we saw on race, which was only present in the Penn-Geisinger study, Walmart's data didn't have great racial data, was unfortunately simply smaller effects for minority populations than white populations. And there's a host of reasons why that might be the case, from trust to access, but that was disappointing, certainly. And then I guess the other thing that I would say is on timing, and I think, and I might be wrong about this, but my suspicion about when we look at the trials that tried to take our insights to COVID and saw good effects in January, February, not so great in May, I think that the baseline vaccination rate changed so dramatically that having the statistical power to detect any effect essentially became impossible by the time those other trials were launched. So I think, that there's certainly no evidence that these very light touch, low cost tools aren't wise to use in combination with other things, but to expect large returns from them in a late stage of rollout is probably unwise. They might be really useful at this moment for the 5 to 11, 5 to 12 age group. I have a 5-year-old, can't wait to get him vaccinated, and boosters. So that, I think, is where we probably see the best results.
Great, thanks. Linnea, lots of questions around the design of the lottery. One interesting one I thought maybe you could speak to is, we did the targeting based on zip code. And what different results might we have expected if that targeting had been on a different either geographic basis, like neighborhood, which is different from zip code, or even like social identity or occupational identity?
Yeah, that's a great question. It would be pure speculation to suggest where those would lead us, but I think
prerogative.
yeah, I think it's helpful though to think about the trade-offs in these designs, and there were a lot of trade-offs we considered early on as we were thinking about how to design the lottery, and one of those was we really want to be able to randomize, but at what unit, at what level? Some of us, we were talking about focusing just on people who weren't yet vaccinated and randomizing in some way within just the non-vaccinated community. But with that, you potentially create a perverse incentive when boosters come along, or these, God forbid, another pandemic, where people are waiting for the incentive, waiting to be special, and so hold off on getting vaccinated. So we knew we didn't want to focus there. As for other socioeconomic or demographic variables, I think we just wanted to very much avoid appearing unfair. Like, the whole point was to be as equitable as possible while still focusing on the underserved communities that didn't have as much vaccination or access to vaccines earlier on in the rollout. So that's kind of how we arrived at that. But I love the idea of neighborhood. That would be great if we could operationalize it, because you could imagine how you could do more local marketing to really raise awareness. So if there's a policymaker out there who's interested, maybe think about neighborhoods, because it might be easier to marry those odds with awareness.
I think there's easier marketing when it's fair amount versus 1913.
Exactly.
Sure. Harsha, there's been lots of debate, certainly on Twitter, where some of us, spend some time in the bubble, about the accumulating evidence on lotteries and incentives. And some folks pretty quick to say they didn't work. Where other folks saying, like, are we really ready to say that? There's some individual incentive program studies that are coming out. There's some other synthesis work, like the study you presented. How do we know when we're sort of ready to say these worked or these didn't? Where else is sort of the R&D on future research that's needed to have a more kind of precise and maybe robust answer to that question?
Yeah, Allison, I think the researcher in me says, like, we really should be empirically studying this question. I really like the trials that were done. Well, in addition to the Philly Vax sweepstakes, I like the trials that were done in Sweden, the one that was done with Medicaid managed care beneficiaries in California, because I feel like those rapid studies can at least tell us, in a specific context, in a specific setting, do incentives work? I think the conclusion we're drawing from our paper is that there's going to be tremendous heterogeneity. Like, it may not work in some places, but in other places it may be what's necessary. It comes down to some of these subgroup analyses. I think are informative because they tell us, like, which are the populations and settings in which these incentives are more likely to be effective. So I think in terms of how we should approach this going forward, so let's say next year there's another phase of the vaccine rollout during which we need to determine whether incentives or other interventions are being introduced. I think the subgroup analyses from these various studies can be informative in suggesting whether some settings and populations should be offered these types of rewards. And other rapid trials where you can do, say, take a smaller population and rapidly assess whether there's movement in the vaccination rates or not. I think that could be a useful way as well.
It's a great way to think about it. Our clock is ticking down, so I'm going to do one last lightning round with maybe just a 15 or 30-second response from all of you panelists, and you can actually pick the prompt to respond to. Either, what have we learned here that we can apply to 5 to 11s as the vaccine rolls out there? Is there anything we've learned? Or really interesting question in the Q&A around, why aren't altruism messages working here? Like, isn't that the rational response, that I should just get this vaccine because it's the right thing to do for society and will protect other people? That person feeling some tension between that and, like, trying a lottery that pays people. So you can, I think one of those is harder than the other to answer, and you're welcome to pick. Katie, we'll start with you.
Start with someone else.
I want to pick more. Linnea.
Okay, I'll bite. I think, given I was closer to the vaccine lottery, I will comment on the application to 5 to 11-year-olds, since wasn't really much altruism involved in what we were doing. I have no idea if a 5 to 11-year-old will respond to a lottery. Maybe their parents will, for sure. You could potentially experiment with different incentives, like access to meet the creators of Paw Patrol, or something else that polls well with 5-year-olds today. But all jokes aside, I mean, I think Katie made this point that some of these techniques, messaging or lotteries or incentives, are going to work at different stages. We are at an early stage with that population, so maybe this is the time to try a lottery again.
Harsha.
Yeah, I mean, I think on the basis of just looking at the analysis that we did in our paper, I would suggest not going forward that way because I don't see the evidence in the data yet to support that.
All right, no
sorry.
escape, Katie.
Sorry for being slow. I mean, as I just said in the chat, I think I'm less hesitant than Harsha sorry to use the hesitant word since that has lots of other meanings here, but I'm less hesitant to say we need more research on incentives in the US at this point and more ready to conclude that, okay, they worked in Sweden, but it's a really different climate. And I haven't seen a single bit of evidence for their efficacy in the United States at the levels that, have been tested. So we don't know I don't want to rule out things like $1,000 a month or even $1,000 one time, but up to a couple $100, which is what I guess I have seen, doesn't seem to do anything, and it's expensive. So I think we should be looking at other strategies, and certainly the evidence on mandates is extremely strong right now.
It's going to be really interesting as the 5 to 11s roll out. We already have existing mandates in every state for school entry, and whether and how the COVID vaccine is added to those mandates, and both the political and the epidemiological implications of that are going to be really interesting. Let me hand over to Kevin to wrap us up. This hour went very fast, as we knew it would. Kevin Bolt.
All right, well, thank you to our panelists and to our audience for a spirited dialogue. I think it's important to pause here on the context where vaccination rates had started to plateau. Most of the US population weren't vaccinated. That's where the interest in using incentives came in. Nobody was using incentives as part of early rollouts. And I think it's important to recognize that in many states, I think incentives were being used in the hope that they would be effective and more paternalistic approaches like mandates would not be necessary. So I think what the studies have shown is that while incentives have been shown to increase healthy behaviors in many contexts, that did not appear to be the case in the context of COVID, leaving the study in Sweden aside. And that was true here, both in terms of incentives with small expected value, direct incentives, lottery type incentives, but all of them had pretty small expected values, and increasing the odds of winning, as Linnea described, didn't seem to really make much difference. We do see evidence that low-cost text message nudges can increase vaccination rates, particularly if they draw on notions of scarcity and ownership with reserve for you type language. And I want to highlight the methodological innovation here in terms of the mega studies, in terms of the speed of learning. I think this is in itself quite important. Typically, researchers test 1 or 2 ideas at a time against a control. And in both of these studies, roughly 20 ideas were tested at the same time, really accelerating the learning process and creating a paradigm that could be used for future innovation efforts. But I think it's also important here to acknowledge that the most effective interventions increased rates by about 4 to 5 percentage points on a base of about 42%. So it's about a 10 percentage point increase. It's a low cost way to get lots of additional people vaccinated, but clearly that in itself wasn't going to solve our challenges in the US in terms of vaccine hesitancy. So I think what we've realized from a lot of this work is that lighter touch nudges of the kind described here in themselves are unlikely to address vaccine hesitancy in the US, given how polarized things have become. And for that reason, we've needed to use much stronger approaches, various conditional incentives in terms of requiring vaccination for access to restaurants in some cities, sporting events, sometimes workplaces. And that's why mandates, in essence, have become required in so many settings. And as we move forward with this and other public health emergencies, there's going to be a lot of ongoing challenges balancing individual choice and the impact of those decisions on the well-being of others and the economy that leaders in both the private and public sector are going to have to grapple with. And it's going to be an ongoing challenge to figure out how hard should we push people in contexts like vaccination, where behaviors both affect your own individual risk and the risk to others. So let me conclude by thanking all of our panelists and thank you to all of you for joining us today.